Tired of dealing with vein disease? Have your symptoms gotten worse?
Yeah, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, there you are. I was hoping you'd drop in. We talk to you. It's like we're talking to one person every week when we do our show. Dr. Juliff is the medical director of Vein Clinics of Hawaii on 4 islands, started on the Big Island, and, kind of circuitously ended up here on Oahu. And Vein Clinics of Hawaii is in my opinion, right out in front of where they need to be. Not only do I host the show gladly every week, but I'm also a patient. And I can tell you along the way, and we talked to you a little bit in the past about this, there are a lot of misconceptions and myths about vein disease. And that's what we're going to do today. We're going to do a show on some of these things. And we're going to start out, Dr. Juliff, by talking about the difference between a spider vein and a varicose vein, and what something looks at may not be anywhere near accurate. I mean, a lot of people really, really misunderstand the whole profession that you're in.
Right. There are a lot of misconceptions. And, a lot of that has to do with the fact that, which is a good thing, but, the technology and the treatment modalities that we have nowadays are so much different than they were in the past, prior to 20 years ago, et cetera. And so a lot of people have misconceptions about what they might have to go through if they come in and see us, and they have these visions of either mom or grandma or whoever that was in the hospital for days and had surgical vein stripping and all this sort of stuff that we don't do anymore. So it really is a relatively speaking, a very new field. Mm-hmm. And so there are misconceptions there. And we have to also be careful. There's so much information that we kind of take for granted because, we're working with it day in and day out. But a lot of people come in and they don't really know the difference between spider veins and varicose veins. Mm-hmm. And they are two very completely different things. And they also may or may not imply two very different things too. Spider veins are those, they're the tiniest of veins, and they're the most superficial. So,
and aren't they the ones you can also see?
Yeah, you can see them. Spider veins and varicose veins are the things that people see on the surface of their legs, and luckily those are the things that people are most likely to connect with, venous disease. I mean, it's easy for a patient to say, "Gee, I've got a varicose vein. I must have a vein problem." Unlike some of the other symptoms that we'll talk about later, but. It's an easy connection, and most people make that easily. But spider veins are the tiny little, blue-red kind of veins that we see. We call them spider veins, I guess, because they sort of look like spider webs. Sometimes there are different patterns to spider veins that after you look at a whole bunch of them, they sort of take on patterns. But they're from an anatomic standpoint, they are different than varicose veins.
Mm-hmm. Well, here's the thing. And by the way, gang, as I told you, the Vein Clinics of Hawaii took a circuitous route on how to get to Oahu, and so did Dr. Juliff take a circuitous route how to get into the specialty because he was a cardiosurgeon. And I guess when you were doing that kind of surgery, people come in kind of on a gurney and they need some help like right this minute.
Right.
And yet when you take a look at vein disease, and with the modern way that you're treating it now, it's a wonder to me how way back in the beginning of medicine, this condition even got recognized, and certainly how it got treated. I remember seeing people would have leeches on them, and they would be bloodletting and doing all of these crazy things.
Right, yeah.
It hasn't come, like they say, it come a long way.
Yeah. Well, it's interesting to read about, very past history kind of ways of treating not only medical problems in general, but specifically vascular and venous kind of things. But yeah, way back in the ancient times, people were doing things like bloodletting and, trying to, for instance, decompress a varicose vein by, incising it and letting the blood come out. Well, obviously that blood just kept coming out.
Yeah.
The vein didn't decompress. But so yeah, it's fun.
But
to read about that.
But it was recognized as a condition that needed to be treated somehow.
Yeah, on the other hand, when you look at guys like Hippocrates. There was somebody else back in ancient times named Galen, Galen, and it's amazing the amount of real anatomy and physiology that they really did understand. For instance, Hippocrates kind of made the connection between venous disease and chronic ulceration.
Wow.
Well, that was a long time ago, and they also found that there was a benefit to wrapping legs, which is, comparable to our, modern day medical grade compression stockings. It's really fun to read about that stuff. But the thing about vein disease is that there's been such a tremendous revolution of how we treat vein disease, even from 20, 30 years ago.
Yeah, I was going to say that, gang. When we're talking about skipping back and forth from Hippocrates, some of the treatments and some of the conditions and some of the diagnostic equipment is only a couple of generations old. I mean,
right.
If you look at a generation of being plus or minus 20 years, or a little bit more, certainly the kind of ultrasound examination that I have in your office 20 years ago was not in 99% of vein doctors' offices.
Right. Yeah.
As a matter of fact, there weren't that many vein doctors.
Yeah. Right. Exactly. Exactly.
Yeah.
It's just all improved. Not only our ability to treat, the devices and the procedures that we have today are so different and so more easily tolerated, et cetera. But also the devices that we use to diagnose, like ultrasound, we use it very, very extensively.
Okay, now there's also, gang, and I've learned this over the years working with Doc, and not only do I get to facilitate and host the show, but I'm a patient, and I've had a lot of procedures, and I'm happy to discuss them and talk about them because I think it's important that we look at these things. But there's a lot of things that people shouldn't feel guilty that they have caused this. You inherit it. But then there are some things that may irritate it. The first thing that always comes up, and it's usually women, and they're wearing these beautiful high heels that their calves get really accentuated, and it's gorgeous and it's beautiful. Does it hurt?
Yeah. Right. It's kind of an old wives' tale sort of thing about high heels. Do high heels lead to varicose veins? And from a theoretic standpoint, could they? Well, yeah, I guess, because there's this thing that we call the calf muscle pump, and the calf muscle pump has to do with facilitating venous function, because we don't have a lot of little hearts all over the periphery of our body pushing blood through the venous system. The venous system relies on two things: muscle activity, and then also these tiny little one-way valves that occur in veins that keep the blood moving in the right direction. So what happens is that a muscle contracts, it compresses a vein. The blood within that vein then has to move somewhere, and hopefully it's going to move upward if those little one-way valves
by design, it's supposed to go upwards.
It's supposed to go up, yeah. So, and what happens when people develop venous insufficiency is that those valves fail, and typically that's what we inherit from parents and grandparents, the propensity for those valves to fail. So if you are wearing a high heel shoe, is that going to then lead to varicose veins and venous insufficiency? Well, no, not really. Is it going to be while you're wearing those shoes? there is a lack of calf muscle contraction because your ankle is in one position. While you're walking, normally the foot is going up and down, flexing in one way or the other, and that is what's causing the calf muscle to contract and therefore facilitate vein function. So the basic answer to that is probably not. You would have to wear a high heel shoe essentially 24 hours a day, 7 days a week to really impact vein function. Now, on the other hand,
okay, ladies, relax. It's not as bad as you thought.
You can wear the shoes.
Yeah.
More importantly, you can keep buying them. But on the other hand, however, we do see people occasionally with neuromuscular kind of disorders where the calf muscle maybe is non-functional. And that doesn't change. Obviously, if somebody has a disease process that is affecting their muscular activity within one limb or another, that's permanent. For instance, and I think the best example of that is somebody who's had polio in the past.
That's really important because that's something that's licked.
Mm-hmm.
For the greater part. But it is interesting, and I think maybe another concern, a myth around that when I first saw that, when you start talking about it, is the same thing happens with women that cross their legs.
Yeah.
I didn't used to be able to do that. My legs got in the way. But now that I am, I can see why it's a habit.
Yeah.
And sometimes, does it contribute to a worsening condition if you have varicose veins? Is it a problem?
Well, if you already have varicose veins, it might. But I think the misconception is that crossing your legs a lot is going to lead to venous insufficiency and varicose veins.
Okay.
And the answer to that is no, it does not. And I think that again, venous insufficiency is from a breakdown of the function of those one-way valves, and just because you're crossing your leg, that doesn't mean that's going to happen. It's usually a genetic thing, and and that's going to happen over the course of your life if with other factors kind of impacting it. But I think the problem or the reason that people kind of were led into that idea that crossing your legs is going to lead to, vein issues is because often that's where we see varicose veins arising in the area on the inside of your leg.
Is that just a coincidence, probably? Just because of the
area?
No,
it's not a coincidence. It's there are anatomic reasons why we often see varicose veins in that area.
Okay.
Because one of the superficial veins called the great saphenous vein runs right in that area and branches off of that saphenous vein. If the saphenous vein is failing, then branches off of that vein can become dilated, and those are what we see as varicose veins. So I think it's because of that. It's also because of the fact that when you cross your legs, sometimes your foot goes numb or whatever, and I think a lot of people think of that as causing a circulatory problem. When you sit in a particular pattern, then your foot may go numb. You have that numbness and tingling, and it's usually not a vascular thing. It's usually a nerve thing.
But what's interesting to me is that how often that's one of those myths that you think, and a lot of people unfortunately relate to that to sitting for a long period of time with your legs crossed.
Yeah.
In some cases, as we get older, I just guess sitting in a toilet for a long time, when you get up, your legs don't work.
Right.
They're asleep or whatever you want to call it.
Yeah.
And so a lot of people say, it's it's my veins. It's I got a problem here.
Well, and a lot of most people jump to the concept that you're doing something to the circulation. Not necessarily veins or arteries, but my circulation is being cut off. And typically in that situation, no, it's not. It's definitely a nerve thing, and it's just kind of ultimately finding a position that's going to be comfortable for you and not lead to that.
Yeah, and gang, this is really important because as you learn some of these things, you learn, and unfortunately, what I've learned over the past several years is that this is a disease that comes on really, really kind of slowly. And you don't realize how bad it is sometimes until it's pretty well developed, pretty big. And then the other side of it is, and I think that we can just knock this myth right out of the park in a minute, because I'm at your office often and for treatment and diagnoses, and I see a lot of men, and it usually was something that, well, men don't have men don't have varicose veins, for heaven's sakes.
Right. Yeah, that's one of those myths that vein disease is primarily a woman's disease, and it is a little more weighted in the direction of women. There's no question about that, and that's because of the fact that women get pregnant, and pregnancy is one of those periods of time when, if a woman does have that genetic predisposition to form varicose veins and venous insufficiency, then very likely she's going to in one way or another. Now, luckily, women, they go through a pregnancy, and then after they deliver, then their venous function sort of returns to normal. I think probably that happens most of the time, but in a good number of women, it doesn't, or with each successive pregnancy, their veins may get a little worse until, after the second or third child, they say, gee, this is not going to go away. I need to go in and get it fixed.
That, by the way, that's another point. Maybe you could address that for just a minute. Is that a lot of times, when people have conditions, let's say a woman has varicose veins that you're helping her with, and then she gets pregnant.
Yeah.
And now all of a sudden she's pregnant, and from what I understand, it's not, you don't perform multiple vein or vein surgeries when somebody's pregnant. Why not?
Yeah. Well, we anything that's elective, which 99.99% of the time, vein procedures are totally elective. But anytime someone is pregnant, we don't do elective things to that person, just because of the fact that we do use some medication, and we don't want the chance of anything affecting the pregnancy, so we just stay away from it completely.
By the way, one myth I want to make sure that we get into this, and that is when you say elective, that makes, I don't want people to think that it is just up to you whether you have vein surgery or not.
Yeah.
It is elective once you've been given the prognosis or the diagnosis from your doc and the treatment plan. Then it's elective if you're going to follow it. But I would imagine with some people, he's saying this part of it you really need to do because this is threatening you in one way or another.
Yeah, elective does not necessarily mean not medically indicated.
Okay.
Most of the procedures we do are certainly medically indicated. It's just that they're elective, and we can do them on whatever is convenient for the patient, as opposed to an emergency surgery.
Gotcha.
There's either elective or emergent. Most of the stuff that we do is elective, as opposed to cosmetic.
Yeah.
It's not cosmetic. It's medically necessary, but it's an elective type procedure.
Okay, we often talk about venous ulcers and things. Let's say that somebody, and by the way, there's another condition here, gang, that women are getting pregnant later in life in current generations than they were before.
Yeah.
Because didn't they used to do, babies, get married, have babies.
Sure.
Now they have careers and then they have babies. And I'm thinking that some of this stuff, as some of these gals get older, are what happens if somebody that has vein issues develops an ulcer, a venous ulcer when they're pregnant. Don't they need treatment for that? Or is that something that can be managed for a while? Or
yeah, something like that we would manage. There are ways to manage that conservatively, with the non-interventional kind of treatment things. And that's what we would do. We would treat that conservatively and not do anything even minimally invasive, or certainly give that patient any medication that she doesn't absolutely need. So there are ways around that, sure.
Yeah, the reason I ask is because there was recently stories I'm sure a lot of our listeners have heard about pushback from parents on how many inoculations and vaccinations little kids are getting. And no matter where somebody is on that issue, doesn't a practitioner like yourself in the vein issue with somebody who is pregnant, even though something needs to be treated, you'd say management's the tool here.
Yeah. Well, even when we know it needs to be treated, and even when it would be very, very unlikely that any of the medications that we would give, over the course of the types of procedures that we do, it's very, very unlikely that any of them would cause any birth defects. We just don't even want to take any chance. Getting back to the male versus female issue, other than pregnancy, and then also the hormonal changes that happen over the course of a woman's life, which in and of itself also can sort of lead to vein problems if that patient is genetically set up for it. But all the other risk factors also apply to men. For instance, age, obesity, working on your feet, for long periods of time, genetics, all of those things also affect men. So, I think in my experience, probably, the number I always use is about 40%.
I see that just as a patient in your office. That's exactly about the makeup in there.
So, I think at least 40% of our patients are men. But again, overall, it's a little more weighted toward women. But the other thing about men is that they probably present to us a little later.
I was going to say, I know this for a fact because a lot of my friends that have beaten path down to doc's office and me, we're getting longer in the tooth, whatever that means. By the way, I found out from a dentist friend what that expression means. It's because your gums are receding. And so your teeth get longer. That's longer in the tooth. That's a little factoid for you. But seriously, I think that a lot of men postpone things too. And they're certainly not usually as critical of the way things look. Although here in Hawaii, that might be a little bit more because of how many of us go to the beach and wear shorts a lot.
And that's another trend that we're kind of seeing, and which is rightly so, is that I think more and more men are becoming a little more concerned about the appearance. And whereas in the past, I think we were primarily doing, for instance, sclerotherapy for spider veins, primarily in women. As the years go by, we're seeing more and more men want to come in and have their spider veins cleaned up. Hey, there's nothing wrong with that whatsoever. I mean, everybody wants their legs to look good.
Yeah, and by the way, it's not only look good, because one of the things that I think is important, you mentioned that earlier, I think that a lot of you out there don't realize how much standing up you do. For instance, if you are a doctor or a dentist or a hairstylist or a salesperson on a retail floor, you are on your legs and on your feet all day, really.
Right. And that is a risk factor for developing venous insufficiency. And the other thing about spider veins is that people who have only spider veins, they may not have anything else visible on the surface of their legs. That may not be just an isolated thing. Spider veins can be a part of this overall thing that we call venous insufficiency. So, getting back to men, wanting to be evaluated for their spider veins, they should be, especially if they're having other symptoms that typically go along with venous insufficiency, like achiness, heaviness, fatigue, muscle cramping, restless leg syndrome, all those types of things. If they have spider veins and then in addition other symptoms, by all means, they need to be looked at, and we need to figure out whether they have venous insufficiency.
What about hard workers? I mean, we're all hard workers in our way, but let's say construction guys, for instance. They're on their feet all day. Even an operator, a crane operator or something, is physically doing stuff all day. Does that make venous conditions worse? Does strenuous physical activity contribute to more serious vein disease?
Yeah, it can, because some of the people that you just described, people they're on their feet all day long. But in addition to that, they're also doing a fair bit of lifting and straining with the upper body actually can lead to pressure on within the venous system that can lead to further worsening. Again, if you have the genetics to develop venous insufficiency. So many people with those genetics, if they have parents or grandparents that have had varicose veins or vein problems in the past, the likelihood that they're going to have them is pretty great. So if you put on top of that then a profession like retail, hairstylist, and they're on their
dentist,
feet all
doctor,
day,
everybody,
dentist, doctor, pharmacist, nurses, they're going to be even that more likely. Now, if you put on top of that, it's kind of a layering of risk factors. If you put on top of that somebody who's not only on their feet all day day long, but straining, with their upper body a lot, then they're going to
carrying stuff around a construction site, for example. But here's another one, and I got this from a friend of mine who's a policeman, and he's getting near retirement age, and he's trying to maximize his income. And one of the things they do is they take these special duties, special things on. And if they're around construction, which is going on a lot now, they are on their feet for 8 or 10 hours.
Right.
And that's a long time.
Yes.
And they get home and they're exhausted. And that's not just unhealthy, but that's also contributing to your not being able to work or not feel comfortable when you're working, and therefore maybe not be able to take those jobs.
Yeah. Limiting your work life. And as people are getting older and requiring some income, that's going to impact that. It's I would, one of the or telltale kind of signs of venous insufficiency that we ask about are people who come home at the end of the day and their legs are achy. Sure. And I think it's easy for people to kind of rationalize that and say, gee, well, I was on my feet all day long. My legs are tired. That's sort of rational thinking. But there might be something more going on. And what we ask people is, at the end of the day, do you come home? Do your legs feel fatigued and heavy? Mm-hmm. And do you feel like you need to elevate your legs to make them feel better? And that's sort of a surefire sign of this thing, venous insufficiency, and we read a lot into that symptom.
We hear a lot about high blood pressure, and we hear a lot about stress, and people with high blood pressure are stressed. One case in point, one example was this lady that I met that worked in the city and county in the Department of Motor Vehicles, and stood all day at a counter working with very mad clients, that are really jammed up, and the paperwork's a mess, and it's stressful, and they want to blame somebody, so they blame the lady, and the lady's trying to be nice, but this is a stressful thing.
Sure.
And she got to a point where she'd go home and literally drink a bottle of wine and go to sleep because she was all stressed out. Can stress contribute to additional problems with venous insufficiency?
Probably not. Probably not the way that stress can affect
does high blood pressure?
Other things, like your blood pressure. I mean, your blood pressure. Well, everybody's blood pressure kind of fluctuates throughout the day. But I mean, when you're stressed out, your blood pressure definitely goes up. And if that's a repetitive, constant kind of thing, then it's going to take its toll. But probably not the same thing for venous disease. No.
Okay, well, the good news is that all of these things that we're talking about, and those of you that are saying, that's me, I stand up all day, or it feels like I stand up all day. I was talking to a gardener in my neighborhood who does some stuff for us from time to time, and I didn't realize this, but he says, I'm retiring. I said, really? First of all, I couldn't believe how old he was. He didn't look his age by any means. Yeah. But he said, I just can't stand up like I used to. I can't do the yard. I can't clean yard like I used to.
Right.
So that becomes an issue. So I'm thinking that more and more of us need to work longer and longer, so that somebody taking a look at getting examined for varicose veins and treatment, it's not cosmetic at all.
Yeah.
It's financial.
Well, financial and also quality of life too. I mean, I think a lot of people, as they get older, they have kind of aches and pains, and they just chalk it up to old age. I mean, we hear that all the time. Where somebody will come in and they will get treated, and then afterward they'll say, "Gee, doc, I didn't really realize how bad my legs felt because they feel great now after we've fixed their venous insufficiency." And when people get into their retirement age, even if they don't have to work, they certainly want to enjoy life.
Well, here a case in point. I know a couple of people, and I know you hear this all the time. There's sometimes, once you get older and you have the venous conditions that we talk about on the program, and by the way, a lot of this is covered at the website, veinclinicsofhawaii.com. You got to really check it out. Shows you a lot of before and after, shows some of the scope and some of the things that Doc does and what his staff are like. But a lot of people have either a bucket list or the desire to really travel and visit and do things that they couldn't do. So they work hard, they build up a nest egg, they have this opportunity to go, and they just can't. isn't sometimes travel just not a good idea if you have advanced venous issues?
Definitely. People with venous insufficiency, one of the things that we talk about all the time is there is an increased risk of DVT, deep venous thrombosis, or, leg blood clot. In people with venous insufficiency, then, again, kind of along the lines of layering the risk factors. So if you have venous insufficiency and then you go on an 8-hour plane ride, then you're having even additional risk of developing a DVT. So, and then, if your symptoms are bad enough, then just being mobile enough to enjoy travel, that's the other thing. So, it's never too late to look into this stuff. If you're having symptoms related to your legs, because often we can make people feel quite a bit better.
I do know one thing too, gang, and this is right now particularly with this threat of this pandemic, if you will, this coronavirus, that there used to be a pretty good series of instructions that doc would give you if you're going to insist upon traveling, even though it's not indicated it's a good idea. Compression stockings, if you don't wear them during the week or regularly, you should wear them on an airplane. But it used to be wander around the cabin and walk around, and now they're telling you sit in the corner, don't move, stay seated. It's a challenge. Yeah. So what would you recommend if somebody now has got to travel? What can they do if they can't get up and stretch their legs?
Yeah. Well, that would be ideal. I think you touched on the first two things. Compression stockings, for sure. Yeah. And do you need, there's two types of compression stockings that we use routinely. One is a knee high, comes up just to below the knee, and then one is a thigh high that comes up to the upper thigh. Do you need the thigh high? No, not really. Yeah. Probably a knee high compression stocking is adequate in that setting. But, would definitely wear compression. Stay well hydrated. Using something other than vodka. Chardonnay is not a way to stay hydrated. Which actually is a good point. I jest, but alcohol is a diuretic. So as you're drinking more,
you're
alcohol,
getting dehydrated.
You're actually defeating the purpose. But so drink plenty of non-alcoholic beverages. Otherwise, so stay well hydrated, and then muscular activity. Do you have to get up and walk around the plane? No, you don't. You can actually, periodically, and probably you could do this more frequently than you might want to get up and walk around the cabin. But just flexing the foot up and down, or pushing your toes against the floor, or whatever kind of footrest you have in front of you. But just those kind of you want to keep the muscles of the legs contracting, and whatever way you can do that is probably adequate, because again,
I sit there and just point my toes, stand on my heels. But here's another one, and I don't know, I don't mean to sound funny or disrespectful for people to do this, but when you sit for a long time and you don't move around, this is just not good for you anyway.
Sure.
But you are now almost defying the rules, because you're not supposed to do this anyway.
Yeah.
And so that makes one think, not just in the compression hose, but in some of the other things you can do is to really consider whether you really need to travel in some cases, and what would constitute when you might tell a patient it is not a good idea for you to travel because of these DVTs you talk about.
Yeah. Well,
if I have one, am I going to get another one?
Yeah, would there be a situation where someone would be at so risk of developing a DVT that you would tell them absolutely not to travel? I mean, that's probably a rare event. But if there was, if someone was at very, very high risk of developing a DVT, but they weren't able to be, fully treated. For instance, if there was a genetic component to them developing deep vein thrombosis, and we weren't able to treat them fully with, for instance, anticoagulation or something, then, maybe in that situation you may think twice. But I think for the most part, there are plenty of ways that we can be careful and prophylactically treat people such that they should not, if they're aware. Yeah. And I think that's the general advertising that has gone on about blood thinners in general.
Yeah. By the way, I see them every
All the
single
time.
day.
Yeah.
And when they list the side effects, you think, I'll take the disease. I don't want the medicine. It's
Right.
scary.
Yeah. But there've been a fair amount of advertising in recent years about the newer blood thinners, and that's happening because there have been newly developed blood thinners. We don't have to rely just on warfarin or Coumadin like we did in years gone by. But so that marketing has they're marketing for the drug, obviously, but it's also made people more aware of DVT and the risks of developing it. Yeah. So, and that has been a good thing. So I think being aware of your risk of developing DVT is probably 90% of it. And so if you know, if you've had a family member that's had a DVT, or if you have had a DVT, or if you have vein disease or whatever, then you have to be concerned about it. And you'll, at least if you're aware, then you'll start to do some of the things that you need to do, like compression, hydration, mobility.
Okay, and gang, one of the things that we do on the show, and like I said, you go to veinclinicsofhawaii.com and see what we do, and get an idea of the scope of treatment. There's a lot of people that maybe also have another myth, and that is that it's that it is a real slippery slope, and there's not much you can do about it once you've been diagnosed. You talk about the 6 different classes of venous disease, which we talk about a lot. And you may not be able to stop it, but by certain treatment and options and having certain things performed, wouldn't you elongate the period between the worsening stages? In other words, can you somewhat slow things down and stop this deterioration by getting treatment?
Oh, definitely. Yeah. Absolutely.
This is key.
Yeah. That's, I tell people that there are, that we treat people for 3 reasons. Number one is to treat the symptoms that they're having at that time. And you're right, there are 6 classifications of venous disease, and a little depends on where that particular person is on that timeline or that, classification line. When they're at the latter stages, like 4, 5, 6, we get a lot more concern than if they're, down around 1 or 2. But, if we are able to successfully treat them, then not only are we treating their symptoms, not only are we hopefully lessening their risk of DVT, because people with ongoing venous insufficiency are at a higher risk of developing DVT blood clot, but the third reason is to stop the progression. Yeah. And that is particularly important, again, in those latter stages, 4, 5, 6, where people are starting to have skin problems, skin darkening. People can develop rashy kind of changes to the skin. We call that venous eczema. And then ultimately a worsening of the condition of the skin, where it gets thick and fibrotic and eventually can break down and cause chronic ulcerations. So,
well, by the way, excuse me for interrupting, but I also think it's important for people to grasp that the quicker they find out where they are on the chart and start getting treatment plans and suggestions by their doctor, that's going to really either hasten or slow the deterioration. And I know that here we are in such an instant gratification society anymore that we're looking for a magic pill. Right. And I do know that we've talked this about before, but sometimes there's myths out there. Well, you can take there's some pills that will correct venous insufficiency. Are there?
No, not really, because it's a mechanical. There are some medications out there that some people feel may impact the symptoms, in a positive fashion, but and some of them might. Yeah. But it's not like once you have it, is taking a medication going to reverse the process? No, because it's a mechanical process, or it's a mechanical problem, and there has to be a mechanical treatment.
Which is a mechanical answer. Yeah, and that's true. But I also think that a lot of people, and since we're talking about myths today, a lot of people remember what their parents or grandparents went through, and they think that getting treated for venous insufficiency or getting their veins treated is a long, painful, drawn-out thing, and they're going to have to spend some time in the hospital. People still think that.
Yeah. You're right. They do still think that, and it's sort of a hurdle getting those people in who remember what their mother or grandfather went through. Because they should be assured that it's a whole different world these days.
By the way, as you know, gang, I'm not only the host and facilitator, but I'm a patient, and I don't want to say treatment is fun. But that, I don't want Doc mad at me, but certainly treatment is a lot different than it used to be, and it actually is in such an upbeat surrounding that you are in Vein Clinics of Hawaii, that what pain there is serves a greater good. In other words, you might have one pain right now so you elect to have treatment, and then you get some more pain, but the second pain is going to go away in a few days. The other pain's not. Didn't or wouldn't.
Right. What I tell most people is that, the procedures that we do, by and large, it's no worse than going to the dentist.
Yeah.
We use a lot of local anesthesia, and just like when you go to the dentist, when they start to inject the Novocaine, in their case, we use a different we use a medication that's slightly different from that, but it's still, you get to have a little sting when it goes in, but within a matter of seconds, it becomes numb.
By the way, I'm so glad you said that, because I recently had that experience. And what used to be, I remember when they say, this is going to be hurt for a bit, it was like awful. But like you say now, first they put a little topical thing on it, and then the needle that they're using is very small.
Yeah.
And so it might be a little bit uncomfortable, but it's not, I'm out of here.
Right, exactly.
Big difference.
Exactly.
I don't care what you say, I'm out of here. I'm hurt.
When we start to put the local anesthetic in, we use a very, very tiny needle. It's the same size needle that people use when they get Botox.
There you go.
It's tiny, and really, I think that probably there's more discomfort with the medication going in, because it does sting a little bit, the medication itself. And that probably is greater than the actual needle going into the skin. But we try very, very hard to keep it as comfortable as we possibly can for people. And, for the most part, everybody does very, very well. So there's, minimal discomfort. And that's compared to what used to happen with people going into the hospital for 2 or 3 days at a time, and coming out with a bunch of incisions that have to heal. We don't make any incisions anymore.
I was going to say that those days are kind of gone.
Everything we do is done through just little needle puncture sites. But in the old days, people had a bunch of incisions. They had a huge amount of bruising, and it really did take them, a long time to kind of get over that. During which time they could not work, et cetera. But, people really can, unless they have a real physical kind of job, can come in, have procedures, and go to work the next day.
It happened to me. I mean, there was a couple times a few of my treatments ago in Dr. Juliff's office that I said, well, can I have it on a Saturday? So I can recoup over the weekend. He said, no. I mean, you can, but you won't need to.
Yeah.
And I think that's really good. And I do know that there's a lot of concern right now about opioid addiction and some of the other things. And I do know that some people will self-medicate when they have pain. And maybe use, is that a common thing, is to not want to have prescribed pain for varicose veins?
We don't prescribe any pain medication. But not because we're just trying to be mean, but we don't find that people need it in general. Now we do use a fair amount of what are referred to as non-steroidal anti-inflammatory medications like Advil, Aleve, ibuprofen is the generic name for that, and so that acts primarily as an anti-inflammatory. It probably helps with the discomfort a little bit. But by and large, that's all people need. I mean, very, very, very rarely do people ever ask for additional pain medication. And usually we say, no, well, just try to get through, get along with the anti-inflammatories. And invariably they do when they don't feel like they need pain.
Now, are there issues with things like being in the sunshine or swimming or doing that stuff right after surgery?
Yeah, we ask people not to go into the ocean in particular for a couple weeks. And that's mainly from just a infection standpoint.
Gotcha.
There's just too many things that you can catch from the water, but that's about it. With respect to physical activity, we ask people not to do any heavy lifting for about a week. But
I use that as a great excuse not to do yard work. The last time I had a
right.
procedure.
If need, when people request, we give them a letter that says they can't do heavy lifting for longer or whatever. But
well, that's another thing. I mean, I do know that it used to be, like you said, several days in the hospital, sometimes a week off work. Pretty much now, the way you plan things, and you don't have to. I do know there's a line. A lot of people want a lot of work done at once, right? They don't want to keep coming back.
Yeah.
But what about doing a procedure that, and at the same time, treating some spider veins or some other things? How do you differentiate that? Because some of that's elective and some's paid by the insurance and some's not. How do you work that out for patients?
From a practical standpoint, we're not able to do the medically related procedures that we do along with spider veins.
I get it. That's what differentiates it.
And mainly because of the fact that what we're doing with respect to placing the local anesthesia and the other things that we do, when we're doing those things that are a part of treating the medical part of it, it kind of interrupts or affects our ability to see the spider veins.
Okay. Yeah.
So typically, what we like to do is we like to treat the medical part of it, let the patient get over that. Make sure there's no more swelling, bruising, etc. That might get in the way of our ability to visualize spider veins, because those spider veins are so tiny, and there's any number of things can affect our ability to get medication in them.
Yeah. By the way, I mean to make sure that people get this, that because of the modern way of treating these spider veins and the way that you do these little very, very small invasive things, that you can do a lot of work. I mean, somebody can come in. You're not in there for session after session after session for spider veins.
No. We do a fair amount of spider vein injection at one time.
Yeah.
When people come in for a spider vein injection, basically we do both legs, front and back, and we inject as much as we possibly can. So we do a fairly complete job.
You know what I think is neat? Maybe you can explain why this happens to people that freak out when they see, oh, yeah, I just saw my auntie. She just had some veins. Or her legs were all yellow and bruised. It looks like she'd been beaten. Yeah. You have to have a leap of faith as a patient, right? You already know as a practitioner. You told me, and okay, it's going to look ugly. It's going to look pretty ugly before it gets better, but it will.
Yeah.
Yeah, it does.
How
come? How come it does that?
There can be some bruising, and invariably that goes away. But especially if we're doing injection sclerotherapy, for whatever reason, but especially spider veins, people get a little concerned, a little anxious about the fact that, when we inject the medication and for the first 4 or 5 days, it actually looks a little worse.
It does,
before it starts to look better. Now, why does that happen? Well, it's basically the medication that we're using is creating inflammation inside those tiny little spider veins, and that's how they work. That's how the medication works, because it creates inflammation in the lining, and then the vein collapses and the walls stick together, so they become less visible when that happens. But because it's an inflammatory kind of process, they look a little red, and there's a little bit of swelling, a little bit of bruising possibly. Goes on for 4 or 5 days, but then that slowly recedes. Then the spider veins start to look better.
And I got to tell you, gang, one thing. I had this one that was on the top of my left thigh, and I have big hands. It was hard for me to cover the whole thing with my hand, and I cannot find even a trace of it. I mean, I'm looking. I think it can't all be gone, but it is. Isn't it somewhat interesting when you do that treatment? That particular vein that you've treated will never be a problem again, because it's either gone or dissolves. But that doesn't. So maybe it's another myth that once I get it, I'm going to keep getting it. I'm going to keep getting it. Is that true?
Yeah, well, with spider veins, it's hard to know, because it's hard to know whether, is this the same vein that has now come back, or is it a different one in the same area? It's hard to judge that. But unfortunately, people with spider veins, since they have a propensity to develop spider veins, and what I tell people is that we typically don't cure people of your spider veins.
You do of those that are right there that you treat. but maybe not coming back.
Well,
or more.
I think what I tell people is that we're not going to cure you of developing spider veins, whether they're recurrence or whether they're new spider veins popping up, because typically it's a genetic thing. And but what I say is that we help you manage your spider veins, and unfortunately, it is something that has to be managed, and everybody has to kind of make the decision how aggressively they want to be in managing spider veins. Now, that is opposed to the other procedures that we do on the bigger veins, where once we fix an incompetent vein, let's say we identify a vein within the superficial saphenous system that is refluxing, we're going to treat that. Very rarely do we have to go back and fix that vein. With the devices that we use these days, the long-term fix rate is about 95%.
That's terrific.
Yeah,
it really
that's
is.
pretty high when it comes to medical devices, et cetera. So, very, very, very rarely do we ever have to redo anything like that. Spider veins, unfortunately, a little different animal, and we have to, repeatedly treat them. And in people, in patients, whether they're women or men, if they really want to stay on top of it, then typically it's going to take them coming in for injection sclerotherapy about every year.
Okay. Final myth buster. Can I have too much surgery? In other words, a lot of people, they come in with a question saying, okay, well, we're going to treat all of these veins like you're telling me we're going to get rid of them.
Yeah.
What's going to happen when you take my veins out? Don't I need them?
Yeah, dude, am I going to run out of veins?
Yeah.
We hear
that a lot of it.
We hear that question all the time, and the venous system is so extensive, unlike the arterial system, but no, that never happens. Basically, we can treat veins that are incompetent or functioning poorly, and you're still going to have plenty of veins to carry blood back to the heart. And the other thing that I tell them is that, they say, gee, you're going to close down that vein. Am I going to be okay with you closing down that vein? And I say, yeah, not only are you're going to be okay, you're also going to be better.
I was going to say, I got better.
Yeah.
What happened to me is some of these veins that weren't working properly and giving me symptoms. I had pain, I had tingling, I had, it was sometimes hot, sometimes cold. It was awful. Once they were treated, I found, number one, I don't have any recurring pain. I don't have any aches. I can't see them anymore. This is good.
Yeah.
But it takes a leap of faith to do that.
It does, yeah, because there's a fair bit of lack of understanding. Because you're destroying a blood vessel. But the thing to keep in mind is that when you have a refluxing vein, where you have venous insufficiency, that vein is not doing you any favors.
Yeah.
It's working against you.
Sure.
So us closing it down.
So the blood that's trying to go up can't.
Yeah.
And so you tell it, okay, here's another route.
Yeah.
Something happens magically. Isn't that the big magic of what's going on in your body?
Yeah.
I mean, truly.
It is. Yeah, you could say it's magic, but basically what we're doing is that we're forcing the body to reroute blood that was previously going in the wrong direction and find a route to get back to moving in the right direction. That's basically what we're doing by closing a vein.
Yeah, and gang, listen, the learning curve is amazing, and the more you know, the better off you are. So one of the things we often say when Dr. Juleff and I get together is it's all you and your legs need to know. And real quickly, let's make sure that people understand. You can have veins and conditions all over your body, but the legs are the furthest away from your heart. So isn't that where most of our venous insufficiency comes from? Our legs?
Yeah. The legs are anatomically kind of a special place, and the reason for that is gravity. Gravity is trying to pull blood down in our venous system.
That's why elevating your legs tonight feels pretty good. But
yeah.
What if you didn't have to do that? What if you had your compression socks on during the day, and when you got home, instead of lying down, you can walk around the block with the kids?
Yeah, feel great. Feel great.
Okay, well, I hope so. Thanks, Doc. And by the way, if you need to know more, I suggest you go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com, where you can learn a ton of stuff, and it's all very, very valuable. So check it out, and remember, you are what you are, and once you have identified where on this chart of 6 different stages of venous conditions are, you're going to feel so much better. And the Pebble in the Pond works well. Tell all your friends about it. Come back again next week and enjoy the show. In the meantime, go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. See ya.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.